A painless lump is the most common presentation for breast cancer. So if you find something like that, be sure and tell somebody, because some things don't show up on mammograms, some things show up better on ultrasound, but the painful things are going to be more like cysts or some of the benign tumors that we deal with. Not to say that a painful lump can't be breast cancer, but it certainly lowers my suspicion level. People should learn how to do a good self-exam, kind of get to know the lumps in your own breast, so that if you notice a lump that feels completely different than anything you've ever felt before, then that's something that we would need to evaluate. I know that nipple discharge is talked about a lot, but nipple discharge is rarely associated with breast cancer, or rarely a sign of breast cancer, unless there's a lump and you push on the lump and get a nipple discharge. That's usually not a good combination. Part of the self-exam is to raise your arms up over your head and kind of make a touchdown. And if you notice any change in the contour of the breast, such as flattening, dimpling, an area pooching out, or just anything that kind of changes when you do that maneuver, then that area also needs to be addressed.
So tell us kind of what's the recommendation for mammograms as far as how often women should have one, when they should start having one?
Yeah, that's kind of a moving target these days, because it really depends on your own personal risk factors. I know that family history is talked about quite a bit in the breast business, but it's kind of overrated. So I think some ladies think that if they don't have any family history, that they're not at risk for breast cancer. And unfortunately, that's not a protective thing. It just means that you don't have that as a risk factor. But if you do have a significant family history of breast cancer, then we recommend to start screening 10 years younger than the index relative. We recommend a clinical exam every 6 months, and then mammograms starting, depending on your risk factors, sometimes a baseline at 35, sometimes a baseline at 40, and then either every 2 years when you're 40 to 50, and certainly at 50, I would start getting them once a year. If you have other identifiable risk factors, then it may be appropriate to get them annually, beginning at 40. But breast cancer is really a disease of older women, and so the older you get, the higher the risk. And although we all know someone that was diagnosed at a young age, it's really not very common in the younger age population.
Okay, so let's discuss some of the treatment options for a breast cancer patient.
Yeah, there's a lot of different types of breast cancer, and the most favorable subtype is the kind that cannot spread around the breast or around the body. That kind is called non-invasive, and that's usually treated with surgery, sometimes with addition of radiation therapy. Sometimes there's the addition of a pill that can help lower the risk of recurrence. With the more common invasive breast cancers, we usually use a combination of surgery, sometimes systemic therapy, which is the kind that goes all through the rest of your body, and that can either be chemotherapy, it can be targeted therapy, or it can be endocrine therapy that comes in pill form. So I think a lot of ladies think if they have breast cancer, they're automatically signing up for chemotherapy, and that's generally not necessary for most women, depending on the features of the cancer. It's really very individualized treatment that we give these days. Okay. And then radiation therapy is also another weapon that we use, and once again, that's given on an individualized basis, depending on the patient, the patient's age, and also the characteristics of the cancer.
Okay. So you perform a lot of your surgeries at Arkansas Surgical Hospital. Tell us a little bit about why you choose Arkansas Surgical.
I love the surgical hospital. It's a very quiet hospital, and it's very personable, and they care about my patients, and they care about my families, because breast cancer diagnosis really affects all of the family. It may be the patient that has the disease, but her caregivers, spouse, kids, friends, they all are also needing some extra TLC, some extra attention, and the surgical hospital has a very high nurse-to-patient ratio, so they get lots of individualized attention. The rooms are like hotel suites, and so there's an outer room for a family member and an inner room for the patient. Y'all actually provide beds for someone to sleep. They have their own television in the room, so it just really is a state-of-the-art facility for making everyone feel comfortable, because especially the surgery can be very stressful. People don't know what to expect, and so the less stress that we can have around that very important part of their treatment is what I'm going for. We have a very low infection rate. They're very responsive to the things that I need to help my surgeries go well. They just really take care of not only my patients, but their families and me, which is very important.
Yeah, they just go above and beyond.
Above and beyond, yes.
So you touched a little bit on family history. How much does a family history have in affecting a diagnosis for cancer?
Yeah, about 10 to 15% of breast cancers are due to a genetic mutation that might be running in the family. And so what we're looking for are ladies that are diagnosed at a young age. We consider younger than 50, or a clustering of relatives in the family, such as first-degree relatives, a mom, a sister. You can have maternal or paternal aunts, but in general, it's usually one side of the family that has multiple family members, or if the patient herself is diagnosed at a very young age, then we worry about maybe it's something that in her genetic makeup that is the reason that she got breast cancer at a young age. So that's an identifiable risk factor. And if we see a family that looks like they have a very high risk of having a genetic mutation, then we can actually do genetic testing these days that can test for a whole panel of mutations and not just the ones that we've heard about called BRCA, or some people call it BRCA. So we now know that there are other genetic mutations that can contribute to the increased risk, and we can test for those now and take appropriate action.
Okay. So a couple of, I guess, true or false, your weight and level of activity might affect your chances of breast cancer?
That's very true.
Very true. Okay.
Yes.
Okay.
Like I said earlier, obesity is really one of the main risk factors that we see. Sedentary lifestyle, just the healthier you are, that does help lower your risk. It doesn't eliminate your risk, unfortunately, but it does, cut down on your risk factors.
Same thing with smoking, drinking alcohol. Those increase your chances?
Alcohol is the main one that we've identified as far as breast cancer risk. Smoking has many other things that it's responsible for. And if a woman has invasive breast cancer, smoking can sometimes increase the likelihood of pulmonary metastasis or showing up with spots of breast cancer in the lung. But in general, alcohol is more our main one that we try to keep to a minimum.
Okay, so what about some of the true or false, some of these myths? Cell phone usage affects cancer, affects breast cancer. Caffeine, I know I like a couple of Diet Dr. Peppers every day. And so underwire bras, implants, let's talk about some of those.
Yeah, there's a lot of myths out there. And bras, no matter what type of bra you wear, it has nothing to do with breast cancer. Deodorant, you can wear deodorant of any sort, doesn't have anything to do with breast cancer risk. There have been some anecdotal reports of people carrying cell phones in their bra and having breast cancer in the area, but really there's not been any sort of causative link as far as that being something to worry about. Trauma does not cause breast cancer. Sometimes a woman will have an event where they knock their breast, or a grandchild will bump up against them and they find something, but usually that's something they've already had and they just had an opportunity to reach up and find it. Caffeine does not have a role in breast cancer necessarily, but caffeine can aggravate ladies that have fibrocystic change and breast pain due to fibrocystic change. So about 50% of women are sensitive to caffeine. So I tell ladies that present with pain as part of the chief complaint that if they want to cut out their caffeine, or certainly as much as possible, and see if that helps their pain, then they're in the 50% that are sensitive to it. But if it doesn't help their pain, then they're not in the 50% that it affects them. So, it's really just more of a comfort thing as far as the caffeine goes. But some ladies find that it aggravates their cysts. So if they're going to have a Coke, they just realize that it may make their breasts hurt for a little while. So, but it doesn't harm you to drink caffeine.
Yay!
I know, lots of people. Ooh. And certainly another thing too that has come up is hormone replacement therapy. Yes. In general, we're trying to get away from doing long-term hormone replacement therapy. So when a young lady has a hysterectomy or has her ovaries out, and she's put on hormone replacement therapy to try to avoid menopausal symptoms, it is safe to do that until about age 53 or 54, because you're really replacing something that you lost unnaturally. And after the age of 53 to 54, then it starts to become a risk factor the more years that you're on it. And so I know that I see some ladies that are in their 70s and they were placed on hormone replacement therapy in their 40s and told never to get off of it. But the reasons that we put people on it back then, we found out are not valid. And so people, unless they have debilitating menopausal symptoms, really should not be on hormone replacement therapy past, certainly the age of 55.
Okay. So the Race for the Cure is coming up, and you're the medical advisor for the Susan Komen this year.
Yes, ma'am.
Do you want to talk a little bit about that, or just encourage everybody to get out and race?
Yeah, it's really a fun day. It's a real come together day. It's a real touchy feely day because the survivors are in their pink hats and their pink coats and pink shirts, and oftentimes supported by church members and coworkers and family members. And so I see ladies that have in honor of so-and-so or in memory of so-and-so on their back. And it really touches me when it's one of my patients, either from long ago or that's currently going through her treatment for breast cancer. So it's just really a time of coming together. And of course, the money raised by the Arkansas chapter of the Komen Foundation, the vast majority of it does stay local. And they grant money for different projects. There's a grant application process, and so they're very, very good at finding ways to use that money effectively to help women in Arkansas.
Great. That's coming up November
3rd. Yes.
Yes. So it's definitely a very emotional day for the women that get out there and race. All right, so I think we're about to wrap up. We don't have any questions that have come in. So do you have any final comments or?
Well, I just urge ladies to not be afraid of coming in because they found something, because most of the things I see people for are prominent fatty lobules or fluid pockets or just painful spots that aren't really anything. So I tell people to go ahead and take control and find out what it is, because if it's not anything, then you can relieve that stress in your life. And if it is something, it's always better to try to catch it at a small size and take appropriate action.
Well, thank you. And thanks for your impact you've had on so many women and men's lives. I mean, you do a great job, and we appreciate your commitment to Arkansas Surgical Hospital. And thanks to everyone for joining in today, and have a happy Friday.
Thank you so much.